Okay, kia ora koutou, no mai haere mai to tonight's Te Whatu Ora Northern Region Health Coordination Centre and Goodfellow Unit Webinar. My name is Katie McCormick. I'm a nurse practitioner who also works in primary care and for the Goodfellow Unit. Tonight's topic is a critically important topic of wellbeing, your wellbeing and those around you. With the COVID-19 pandemic response and the winter surge combined with staff shortages, this is having an unprecedented impact on the mental health and wellbeing of those in healthcare. Tonight, we have a great panel of expert speakers who will provide practical tips and strategies to promote wellbeing and avoid burnout, and also what to do if you or people you care for are feeling burnt out. Our speakers tonight include Dr. Cheryl Buhay. Cheryl is a Fellow of the Royal Australia and New Zealand College of Psychiatrists, an Honorary Senior Lecturer with the University of Auckland, and a Primary Care Liaison Psychiatrist with Te Whatu Ora Waitemata. Dr. Fiona Moir. Fiona is a Pastoral Care Chair and Wellbeing Curriculum Lead for the Medical Program Directorate and Department of General Practice at the University of Auckland, and Dr. Katie McCormick. Katie is a clinical psychologist with experience in both public and private mental health sectors. Over to you, Cheryl.
Hi, everyone. I'm Cheryl Buhay, a GP Liaison Psychiatrist, and thank you for joining us on your Tuesday evening, and I hope you're having better weather than we are in Auckland right now. For the next 15 minutes, I'm going to cover strategies that you can incorporate in your day to build resilience and to help cope with stress. And I hope that after this session, you will feel motivated to try even one of these tools in order to look after yourselves in times of stress. Just to review the definition of burnout. So burnout is it's an occupational phenomenon that results from chronic workplace stress that has not been successfully managed. And it's defined, it's characterized by 3 dimensions in the ICD-11, that is exhaustion, negativity, cynicism, and having reduced efficacy at work. So burnout is multifactorial, as you can see here. So there are individual factors at play, including our personalities, our values and morals, our coping styles. There's the perceived stigma around stress and mental illness. So some are less likely to disclose or access support even if they need it. And there's stressors outside of work, such as family responsibilities, childcare, financial stress, and so forth. There are significant work-related factors as well, including work overload, such as due to high patient volumes, lack of resources, or the organization feeling poorly managed. And when I presented last time during the Omicron surge, it was a very stressful time. And now the issues are around lack of staffing and increased workload that hasn't changed. There are other work-related factors also, including, high pace of work, workplace bullying, lack of social support, feeling like you don't have any control over your work environment, working in a solo practice, high levels of work-home interference, and ethical dilemmas and moral injury. So moral injury is defined as when we are expected in our work to make choices that conflict with our values and morals. And examples of that include, balancing our own physical and mental health needs with our duty to our patients, and balancing caring for our patients and our families as well. So with high stress, that can lead to burnout and other mental health issues such as depression and anxiety. And in the stress bucket model that you can see here, this, like burnout and other mental health difficulties, occur when the bucket overflows. So to prevent the bucket from overflowing, you need to balance the stress that's coming in to inside the bucket, our coping strategy, so that's the tap that lets the water out. And you also have to factor in the size of the buckets, because we are all different people. And the size of the bucket is influenced by several factors, such as our genetic vulnerability to mental illness, our own mental health histories, developmental factors such as early life experiences, if we've experienced any trauma, and also our physical health state. So from today, I'd really like you to think about developing your self-care plan and evaluate these things. What are the areas in your life that you engage with on a daily basis? and what aspects in these areas cause you to be stressed, and how can these stressors be addressed. And from that, we can start devising, self-care strategies and incorporating things that you love to do, and also what resources are accessible to you. It's important to take small steps and set SMART goals, like specific, measurable, achievable, relevant, and within a time frame, and making self-care a priority. So definitely penciling it in is important. So we have to start with the basics, which is, sleep, diet, exercise, use of substances, and having your own GP to look after your personal medical care. Because we are humans, we rely on homeostasis, which is the process by which we maintain our internal physiological environment within healthy limits. And with stress or allostatic load, homeostasis is not achieved, which leads to negative physical and mental health consequences, such as depression, anxiety, cardiovascular disease. So we therefore need to address the basics as listed here, so we are able to stay resilient and manage stress. First is sleep. So I'm not going to go through this because you give this advice to your patients, I'm sure, and you know a lot about sleep hygiene, but applying these strategies to your own routines, your sleep routines, having regular sleep, looking at your bedtime routine, and also associating the bed with, going to sleep. So it'll be good for you to practice these as well. If some of us are better than others at doing this. In terms of nutrition, eating regularly at a schedule every 3 to 5 hours, not skipping meals, and eating mindfully. So mindful eating, making conscious food choices, developing awareness of hunger and fullness cues, and responding appropriately to those cues, being mindful and present during eating occasions, paying attention to the effect of food on your senses and to your own emotional and physical responses. There's also some diets that have been promoted to help with managing stress. So these two have been mentioned frequently in studies. So the DASH diet and then the Mediterranean diets. So DASH diet is the dietary approaches to stop hypertension. So both these diets regulate cortisol, which is our stress hormone. It reduces inflammation and oxidative stress. It also has benefits for our cardiometabolic health. They promote having foods rich in folate, B vitamins, polyunsaturated fats, which we know have psychological benefits. There's also evidence for psychobiotics because these can affect mood and our host health by regulating the microbial gut-brain axis. So meta-analyses that have been done recently have shown that psychobiotics improve depression and anxiety, more so with depression, even depression due to stress, and also depression from those with non-depressive illnesses. And the strains that they've cited are bifidobacterium and lactobacillus that these exert beneficial effects on mental health. Also, what's good for your foods rich in B vitamins, particularly B12, omega-3 acids, and magnesium. If you go to exercise, regular exercise is good. 150 minutes moderate or 75, sorry, that's meant to be minutes of vigorous exercise or a combination. And combining this with strength training is recommended, aiming for at least 50% of your maximum heart rate, which is 220 beats per minute minus your age. If time is limited, we don't have time to go to the gym and spend 2 or 3 hours a day there. There's also evidence and studies for interval training. So high intensity interval training, or HIIT, allows you to get those similar benefits, but doing bursts of exercise with recovery periods in between. So if you're time poor, try this strategy as an option. Another tool that we use quite a bit for those with high stress and anxiety is sensory modulation, which is using senses like sight, sound, smells, touch, taste, and movement to manage and change your emotional state. So we use that a lot in specialist mental health, and you can use tools and objects like weighted blankets, fidget toys, surrounding yourself with calm colors and lighting, nice smells like aromatherapy and lotions. And some people have benefited from finding out what objects make them feel calm, and having kits, personalized kits at home, at work, or in their cars that help them feel calmer when they're feeling stressed and burnt out. There is diaphragmatic breathing, which is belly breathing, which and this is helpful to do at least 5 minutes twice a day, and it's useful for your sleep as well. I won't go through that in any more detail. In terms of emotions and our thoughts, do plan for laughter. Do factor in something you love and brings you joy on a daily basis. Make it something to look forward to after a busy day at work. Express gratitude. So expressing gratitude reminds us of what is positive in our lives, and it helps us overcome a number of damaging emotions that we build up over a workday, like feeling resentment, regret, frustration, and it helps us with motivation and energy as well. Practice positive self-talk. So talk to yourself in a more compassionate and realistic manner. Don't say, don't be an idiot, you shouldn't have done that. So start framing, doing that self-talk in a more positive and kinder way towards yourself. Let go of perfectionism. So give yourself and others permission to not be perfect with every task that they need to do. Do what you can, and then that will have to be enough. Also challenge negative thinking patterns, so we can have cognitive errors that we have, and that leads us to becoming anxious and depressed. Like, for example, we catastrophize, we think the worst possible outcome, or we tend to focus on the negatives. When 10 things happened in one day, one was positive, or 9 were positive, 1 is negative, we focus on that one negative thing. Also intellectual diversion. So instead of thinking about work, look at other intellectual challenges that you can occupy yourself with. So this is about creating a worry map. This is just a strategy to help let go of worries when you seem to be in a situation that's stressful and you don't have any control of it. So creating a plan takes back that control. So write down what you're worried about. Is it true or false? Make a list of what you can and cannot do about it, what is beyond your control, and create an action plan from the list of things you can do about your worry, and then you can start letting that worry go. The next tip is your connections. It's not just about friends and family, your significant other. It could be your peers, people at work, and your wider community. So improving those connections can help build resilience as well, and you can achieve that through gestures of kindness, checking in with other people, see how they are doing, communicating with one another in a validating way, and acknowledging the other person. So sometimes when we talk to one another at work, well, you shouldn't feel that way, at least you have a job, or you'll be fine. That's not very validating for the other person. So acknowledging our experience helps us calm our nervous system, and it promotes feelings of connectedness towards others. Sixth tip is practicing mindfulness. So I'm trying to do this myself when I'm at home and I'm thinking about 10 things, and I'm trying to attend to what I'm doing, what I'm doing at that point in time. So being in the present moment, being aware, acknowledging and accepting our feelings, thoughts, and how we feel physically. So what I've done personally lately, focusing on one thing at a time. If I'm with family, I'm focusing on family. I leave my phone in the other end of the room, not checking emails, not watching TV and fiddling on my phone, doing admin stuff. So I try to just focus. Meditation is also good for this as well, if that's something you would like to try. And also, there's your peer group that can provide collegial support. As GPs, I know that that's really important. There are mental health resources out there. There's EAP. MAS, MPS, they provide counseling for us doctors. There are helplines out there. You can text or call 1737. There's a counselor on the other end. There's lots of community resources, and also specialist mental health is available if you need any support beyond, what primary care can provide. There's practical supports as well. So it can go anything from childcare to negotiating flexible work options to consider as well. So I'm actually right on time, and I wanted to mention that I did a webinar on the 10th of March through Goodfellow Unit called Self and Team Care. So keeping connected to what matters. And I presented with Amanda Willits, who is our psychologist, and we talked in more depth about these different tools. The webinar recording is still on the Goodfellow website, and there is a handout there that we put together if you want to try mindfulness, sensory modulation. All the resources are there, so please access them if you would like. Thank you.
Awesome. Thank you so much, Cheryl. Really appreciate it. So now we'll be hearing from Fiona.
Kia ora koutou katoa, no Scotland ahau, tēnā tātou katoa. So here we are on a Tuesday evening for those of us who are here live. And I'm just going to share some slides here. Thank you, Cheryl, for that really fantastic start to our evening. And hopefully I can build on that. So I've just got a few things to cover. I'm Fiona Moir. I'm one of the doctors in the Department of General Practice. And I'm just going to go through some of these topics. My PhD is in practitioner well-being. It's something I've got a real passion for. So tonight we're covering burnout. And of course, burnout is pretty common. I mean, about 46% of us in New Zealand at some point will have a diagnosable mental health condition. But with burnout, for instance, in the medical profession, internationally, about 50% of final year medical students have burnout, and that's globally, and very similar across the health professions. And for all the health professions, it is more common in more junior people, not in more senior people, which I think is an interesting thing to know about. So I've got a couple of roles. I work in the Department of General Practice, and I also am a director in a well-being and communication skills business. So I just wanted to remember some of the risk factors that Cheryl was talking about, and thinking about the key point to take home, I think, with burnout and how it works is that it's a person in a system. So you've got a person and you've got a person who's within a system, okay? And you get a sort of mismatch between them. I've put some photos on here so we can be a bit creative in the evening. There's a very good site called Unsplash where you can share other people's photography if you use their names. Photos that they make. So anybody who's doing presenting, that's just a plug for that site. So a mismatch of a person in a system, and this is often what happens to us when we are mismatched with the system. And Maslach, about 20 years ago, in fact, summarized the way that burnout works. Really is, these were the factors that can lead to burnout, risk factors, really organizational risk factors. So we all know about workload, and a high workload, a high perceived workload, and a high actual workload. And control was something that was spoken about already. And I think that's probably the one of the main reasons that it is more junior people who tend to have higher levels of burnout, is we have less autonomy and control when we are more junior. And a lot of these other ones are around your feelings towards your workplace. If you feel you're fairly rewarded, or there's a good sense of community, or you're working someplace that aligns with your sense of fairness and values. So if you don't feel like you fit in, it sort of, is a risk factor if it's sort of, churning away within you. And then we get to these three strands of burnout, the three different dimensions. So the exhaustion is, a core symptom, and it's one people are very commonly aware of. And this middle one, cynicism here, it's really about the way that we interact with others. When we are burnt out, we can become more detached and disconnected from people and from things that are important to us. And then we start to perform in a way that is less than optimal, and we also feel like we're doing that. Multiple consequences, you can see some here. Absenteeism, sort of being at work but not really being there, making minimal effort, Our work suffers. Burnout is linked in the literature to medical error and also attrition and complaints. And of course, we often don't deliver very high quality service. If you imagine, somebody feeling exhausted and disconnected, and there are various costs associated with that. So this is really how it works. But you can't take a person in isolation. It's a person, a particular individual with all these things that matter to them within that system. And one of the factors that is important is control. And I think the more I read about this, the more this seems to come up, is asking yourself, what is possible, given that this is my situation within this, what is it possible for me to have control over? And these are some of the things that people talk about, the tasks that they perform, or how much input you actually have into the decision-making process at your place of work can make a big difference. Choosing what you participate in or not. Do you get any say into your scheduling? One of the interesting things is skills use. So if you are highly skilled in a particular area, but you are not able to use that skill, that can also be something which feeds into burnout. So these things aren't necessarily easy to fix, but they can be fixable sometimes when you discuss things at a team level. And when people are looking at interventions for burnout, it's really good to look at individual strategies, team level strategies, organizational level strategies, and sometimes it needs to be a nationwide lobbying type level of change that needs to occur. And there'll be some leaders here who work in that space, I'm sure, tonight. So asking yourself, what is it possible for you to have control over? And it's quite easy to think, oh, I have control over nothing. But you on a good day can sometimes step back and think there are some small parts where you are able to do that. The main reasons for burnout are really what we call unfavorable job characteristics. And there's two different sides to it. One is the high job demands. So this is the one that's sort of most known. When you have a high workload, a very high demanding, stuff that puts strain on you, stuff that makes you feel drained. This is where the exhaustion comes from. And this high work demands, high job demands, is often what leads to a health impairment pathway. So ongoing high job demands for any of us, at an excessive level, often leads to exhaustion and physical ill health. But the other thing is this low job resources. And low job resources, they think really it's a sort of other pathway, actually. They're like two pathways going on at the same time. And job resources, it's not necessarily sort of having enough equipment and that sort of stuff. It's stuff like a supportive work environment, feeling like you're in a supportive work environment, and also the sorts of things that bolster you and fill you up. So it might be opportunities or things that help you to reach your professional goals. Those are job resources. Things that make you feel fulfilled and energized, and things that help you to learn new sort of things that you're interested in. So these are the sorts of things that are job resources. And the job resources pathway is quite linked to motivation. So when people have very low job resources, they often become demotivated. And I've got these arrows here on this photo someone's taken in a forest of sculpture. Because in COVID, of course, what happened was that the job demands went up and our opportunities for job resources went down. So as Cheryl was talking about before, it sort of made things even trickier than they were before. So how does it present? Well, we've got these three strands. So really thinking about the exhaustion strand, it's sort of, obvious how people would present. Cynical and detachment comes across as an attitudinal thing. So people lose interest. They sort of become disconnected to people, but also to what is meaningful for them sometimes. And people talk about having a callous attitude. Sometimes there's a cynical sort of way of speaking, quite a lot of sarcasm, talking about people like they're not people, chest pain in the waiting room, that sort of stuff. Can be a whole language that goes along with it. Now, it doesn't mean that, many of us haven't done these things or don't talk like that sometimes or whatever. It's more that it becomes a way of being. And it's something to notice really for yourself, I think. And then we start to sort of feel less productive and to be less productive and to not really feel like we're achieving things. And this one probably often comes along a bit later. There's different sorts of patterns to presentation. So it's been interesting reading about burnout because we know that there's these 3 strands, but there really hasn't been very much written about the way in which it presents, which comes first, which symptom comes first. And what they do know now is that it's not a uniform shape. The pattern of burnout development, it's not a one-size-fits-all sort of thing. So there are different trajectories, and somebody's just published an 8-year study actually where they followed through large groups of people and looked at the patterns of symptoms and what actually happened over an 8-year time period. And the most common one, this was about 80% of people had stable low burnout, all 3 of these strands through 8 years. So it's a long thing. Burnout doesn't develop quickly. It could take at least a year or something. For the person who's experiencing it, it sometimes feels like it develops quickly because you suddenly notice it or realize you've had enough. But it actually develops over a longer period of time if you think about the risk factors and the way that it starts. But there was this second pattern of burnout that had exhaustion first. So somebody was just exhausted for quite a long time, and that was the only sort of symptom. And then after that came the other cynicism, and then being less effective and feeling less effective. And so that doesn't mean to say if you're exhausted that you have got burnout, of course, because as we know, there are many other reasons for exhaustion. So what can we do about it? Well, Cheryl's given huge lists of really fantastic evidence-based strategies that individuals can use. And we need to do both. We need to have individual strategies, and we need to be trying to make some sort of systems change or organizational change. And the evidence is clear that you need to do both. And there is increasing evidence for trying to change the system, even in a small way at a team level, by having a talk as a team about what drives individuals in a team more towards feeling burnt out or more towards feeling energized and meeting their work-related goals. That, what gives people meaning in work is different between different people. So we can't assume that others are going to be the same as us. So sometimes you can find some ways of shifting things around within a team. I wanted to point to this resource that I think is really fantastic. So down the bottom, you'll see the National Academy of Medicine Action Collaborative on Clinician Wellbeing. And this site has got lots and lots of regularly updated resources. It has this diagram at the moment showing these 6 elements for addressing burnout. And if you click on a particular element, oh, excuse me, my lights are going off in my office. I'll just put them off here. There we are. If you click on a particular element, it will give you some resources under it, some case studies of examples where some different health places have put these interventions into action, and some things you can print off and use with your own practice. So when I was messing around with this the other day, if you click under enhanced workplace efficiency, you get this thing called the Saving Time Playbook, and it gives you strategies to do things like how can you identify necessary work and how can you share necessary work and stuff like this. So I think as a practice or as a team activity, this is a really brilliant site, and it's always updated. So a bit of a plug for that, for anybody who wants to look up some team-related interventions. A lot of the other stuff that I have come across recently is using this phrase job crafting. And this is really, I think, referring to the fact that we do know that it's an individual within a system. And what you're trying to do is to help that individual within that system to feel more aligned and more energized and to be doing something that is more meaningful to them. And of course, they're the only person that can identify that. What is important to them? Is it flexibility with work or home-life balance, or is it doing particular tasks, or is it the social community at work? And these are the sorts of things that drive us more towards burnout, or more to the opposite of burnout, which is a sense of feeling invigorated and dedicated and absorbed. And I suppose it's worth pausing to consider and think our ultimate goal isn't just to not be burnt out, but it's to be thriving or flourishing or whatever these words are you want to use. But the opposite end of the scale of burnout is feeling invigorated, dedicated, and absorbed. And when have you felt like that? How could you feel like that? Does that feel completely impossible at the moment? Or are there aspects of your work where you get a glimmer of that you can try to get more of? So this idea of job crafting is giving individuals, where possible, any small bits of input into designing your own job and talking about that with your team. So sometimes people will choose to do a minor surgery clinic for a morning or something that they know that they enjoy. And this is, if you want to look any of this stuff, this is the author who writes a lot about job crafting, which I've put here. And certainly there's good evidence for using job crafting in someone who's been off work, who's coming back to the workforce. So asking a person what are the tasks that they find least straining, what would an optimal job look like, and what makes them feel like they're being compensated for what they do, which isn't necessarily money for people. What is interesting with this is we assume that people are the same as us with this, but it's not necessarily the case. Because I do a lot of conflict training and stuff, I quite like managing difficult situations with people arguing, for instance, and that's not something that people commonly like. But people often don't ask what you like to do within your job. So different answers to these questions. So that's that phrase, job crafting. One other thing I wanted to say in terms of interventions is just looking out for each other. Often we get a sense that a colleague is struggling or a family member. In the work context, we can sometimes feel that it's difficult to wonder if we should be saying something. But when you notice that something is wrong in an ongoing way, I suppose I would just be encouraging you to say something. And I've done this with colleagues in various jobs. When you get that uneasy feeling, I think it's important to say something. So we all need a helping hand sometimes, and just reaching out. Obviously, we need to be careful about how we do that, where we do that, when we do that, and thinking about your role first can help. What's your relationship with that person? Do you have a dual role? Are they a younger practitioner and you've got a mentoring, supportive role or a training role? Have you got a friendship role? So I think when you're having these conversations, it can be really useful to sometimes state your role out loud. I've had conversations like this where I've said, I'm just putting my whatever hat on now, and now I'm putting my whatever hat on. And that's worked well. And then just using our training, all of us as health professionals have got our communication skills training. So we have all these skills, normalizing, listening, and empowering. And a lot of the issue with this is not getting over involved. So deciding what your role is and what it is not. And our job here, of course, is to empower and encourage the other person to see their own health professional. So these are obviously just some phrases. This is the phrase I personally use if I have these conversations, which I have several times. I've noticed that, and I'm concerned that it comes from a place of concern. I haven't had a bad response to that when I've said it. If you're wrong and the person's fine, they just think it's nice that you asked, so I haven't had a bad sense where I'm wondering if I'm sensing that. So it's all, coming from me. I have used the phrase, I'm not your doctor. However, I wonder if you thought about seeing your doctor. And that's when I'm a bit further into a conversation like that. And I can feel myself wanting to start to give advice, or they're starting to ask me about something, and I have to sort of make a clear boundary statement. So I just wanted to put this out there as an intervention. I think I believe that peer support is important, and that we should be looking out for each other, especially during difficult times. So that's me at the end of my time. Ngamihi, thank you very much.
Thank you so much, Fiona. That was really interesting. We will now be hearing from Katie. Thanks, Katie.
Hi, good evening, everyone, and thank you for having me tonight. I'm a clinical psychologist and I work with a lot of people who have burnt out. So I don't have slides tonight, but I'm going to be presenting and talking to you as if I'm talking to one of my clients. The model that I'm using tonight is based on my own research, my doctoral thesis, which was on resilience and burnout in psychologists, my own experience of burnout and my clinical experience. So while I'm talking as well, I'd really like you to think about where you might be on the process, where you yourself are, where maybe your colleagues are, as Fiona was just saying, or maybe your own clients. Sorry, I've forgotten the word that you use there for patients. Yeah. So let's start with our, I guess, ideal in terms of how we manage stress. So on this axis is stress, or our internal stress, and the bottom here is time. And this line, this baseline line here, I think of as our baseline well-being. What we see, or what we hope for under stress, is that we have exposure to stress, be it work, and then we have a recovery. Exposure, recovery. Big exposure, bigger recovery. And we can do this for a long, long time. It's very, very sustainable. So these recovery parts might be some of those strategies that Cheryl was talking about. It's very important in terms of thinking about regular breaks, hobbies, holidays, relationships, all of that goes in there. What's really important in this, though, is that you're switching off from work. You're having a break from work. You're not thinking about work. You can turn off. In these bigger stress exposure times, you might have a bit longer in terms of switching off. People talk about how they have a holiday, and on the first week of their holiday, they're still very, very stressed. They're still thinking a lot about work, and it's not until that second week. That's okay. You're still recovering. What happens when we burn out is different. We've already used the word chronic stress. And I think about chronic stress as two types of stress, the frog in the pot and the tiger in the grass. So the frog in the pot is the slow burning stress, the buildup of stress, that we don't really know that we're in trouble until it's too late. The tiger in the grass was COVID. It was sudden, it was unexpected, it was big, and it was dangerous. And it really changed how we worked and how our workloads looked. So again, on here we've got stress, our internal stress levels. Sorry about that. And time. And then this is baseline well-being again. So under chronic stress, like Cheryl was saying, what happens is we go up and we think we're recovering, but we don't quite go down to our baseline again. We cannot switch off. Our brains are geared to threat, to stress. This is where, you know, it can last a long time. I think Fiona was saying years sometimes that we can do this, and our burnout symptoms start to be seen. You know, it might be here we start to feel exhausted. We get fatigued, we get cynical, work becomes hard, we lose our motivation. It's tough. It's really tough. And yet we keep on going. We reach a point though, and this is quite interesting. We kind of reach a plateau after time. You know, this could be a months or years under chronic stress, and then suddenly we're running on empty, we're running on fumes. And I think of this like flight and fight. It's short-lived, but we get a bit of a boost of energy. We might feel panicked, but we kind of can't stop. It's very, very intense. And the other thing is, I think within medical professions, within health professions, because of the loss of insight that happens in this, we can become risky in our jobs. I remember in my first profession, I was working in advertising and design, and I know that I was in this state because I just felt like I couldn't stop. And I was busy. I wasn't able to work. I was working weekends, I was working long hours in the week, and I ordered a wardrobe, and I thought that wardrobe was going to come ready-made, and it came as a kit set. And it was just the smallest thing, but I just broke down. And this is what happens. It's the slightest thing and we fall. And it's like, I think of this as the brain fleeing. It's trying to escape the stressful situation, escape it as quickly as it can, but we cannot physically escape. And clients talk about, I think I just went crazy. I just suddenly couldn't think. I suddenly couldn't concentrate. I suddenly couldn't work. And this is where I often see people, is when they've reached this point. It can be very, very damaging for people and their confidence to have gone through this. And this is why this last part of this process is also really hard, the recovery part. So coming back up to baseline, you've dropped below your baseline wellbeing level here. And this is where we see what I think of as, it's like a traumatic stress response. Any pressure, any reminder of work, it could be an email, it could be someone asking you to do something that you didn't plan for in your day, brings us back to here. We go boom from here very, very quickly back in our brains to, oh my God, do not do that to me again. And we have a big panic. And this is why people can find it really hard to return to work after this happens. And the more pressure we put on this time, on ourselves during this time, the more at risk we are of more intense mental health problems. It's actually very, very problematic. And I think we see that, and we've read that in the news, how devastating people can feel after going through these experiences. So your job here is to get back to baseline. And if this has happened, so much compassion is needed and acceptance that your job is to recover. And it is hard work. And it is about re-establishing those things that may have started to slip out of your life when you were in chronic stress. So areas such as your hobbies, your health, other relationships that you might not have felt you had time for when you were under that constant pressure. It is, it does take some time, and for some people, I think Fiona was saying it's very varied and very different for everyone. That's true here as well. So for some people, they have, when they have the ability and they can, 3 to 6 months off work before returning is actually a really good idea. For other people, obviously for financial reasons or for work commitment reasons, that's not possible. And then we're looking at more of a flexible work plan. So reducing hours, rejigging client or workloads, thinking about areas of work that are more in the recovery place, and thinking about areas of work that are more in that enjoyable place or that controllable place for people. And then it's thinking, okay, well, what can I do differently? How does my life look different? Because we don't want to come back to this. We want to come back to that balance between stress, recovery. And that can take some time as well, thinking about that. Often that does mean some of a shift in values. For me, that meant going back to work and realizing that my old job wasn't for me, and discovering psychology and going, wow, this is new. This is actually really, really exciting, and I want to do this. So, changing jobs, I'm not recommending that, but that is obviously an option. I will think I'm out of time now, so I will stop sharing. But if there are any questions, I'm happy to take. Thank you.
Wonderful. Thank you so much, Katie. I really appreciate that. So we now have some opportunity to answer some questions. If you'd like to pop them through to the question and answer, we can put them forward towards the panel. Cheryl, just at the start there on one of your slides, you mentioned getting some moderate exercise in the afternoon, and I've got Adam just wondering, why would you say is there a specific benefit to afternoon exercise rather than morning exercise?
I guess the message is anytime exercise at any time is better than no exercise. Mm-hmm. There's contradicting evidence around the time when to best exercise. So they say if you exercise in the morning, you've got your high cortisol levels, you're more likely to metabolize fat, you boost your mood and reduce stress levels, and it sets you for the day. It might improve your productivity during the day. But I know personally, I can't wake up at 7 a.m. and do that. But looking at later in the day, in the afternoon, your body is more primed, and like in terms of muscle efficiency, reaction time, you're going to be more able to do like those high intensity interval training exercises, going on the treadmill. And, you know, some people find that even exercising at night has improved sleep. So yeah, there's contradicting evidence. So whatever fits with your you know, other responsibilities and where you can fit it in, that would be great. And you know, like what we're doing work on cardiometabolic health for our patients at the moment. And one of the keynotes I've met recently said, use what resources are available to you. You know, is your practice, like for yourselves, is your practice near a park, or are you near a somewhere that you can do exercises? Do you have stairs in your building? Utilize those, because sometimes you can't get to a gym. It's, you know, not everyone has that access. Yeah, so yeah, that's my answer. Thank you.
Awesome. Thank you, Cheryl. Also, just, I guess this is put out to all three of you. The term burnout can actually be used sort of in a malevolent way within teams as well, where sort of people can say, oh, she's burnt out or he's burnt out. Or how would you manage that, where there might be some level of high stress going on, but that term burnout can actually be quite damaging to your colleagues, I guess?
Well, I guess from a psychiatrist perspective, I think the other analogy is when you say, oh, I'm so depressed, people can say, I'm so depressed, and they're sad for half an hour. Whereas for us in mental health, that's at least 2 weeks of predominantly low mood and lack of enjoyment or pleasure in life. Yeah. So you might say, when you say burnt out, what do you mean by that? And just say, look, there's actually criteria for burnout, and this is from the ICD. Are you meeting this criteria? So it's important to, you know, probe a little bit more about what they mean, and is it a throwaway comment, because it's one of those terms that's used by lay people. And yeah, I don't know if Katie and Fiona, you had anything to
I think, you know, in that sort of way, that's interesting, isn't it? Because that's a bit of a stigmatizing, bullying type, you know, unpleasant comment, isn't it? So what's behind that? So I think that's a verbal arrow to dodge myself. It's like, you know, let that go past. And because it'd be easy to get into a sort of, well, you know, you don't seem so good yourself type, you know, me on a bad day response. So I think I would try to choose not to react in a defensive way if possible, and try and find out, as Cheryl said, what's behind that, and try and turn it into an us against the workload conversation rather than me against you. So I'd be quite sort of friendly and say, oh yeah, I have been a bit tired. It's quite full on here at the moment. You know, was there particular things you were worried about, as if they were being friendly, just to get the conversation going. Yeah. And then turn it into us against the things, you know. And if they were specifically talking about me, I'd say, oh, sorry, were you talking about particular things to do with me? Is that something we should talk about? And then I'd take it somewhere, I would just name that, and then go somewhere private with them for them to give me whatever that feedback was. So I think just try not to have an instant response to something nasty and let it go past and think, interesting arrow there. What was that was about, you know. That's what I would do.
Yeah, thank you. Someone has asked if there's a recovery period from burnout and how long that potentially might be. I mean, I guess how long is a piece of string in some ways, but yeah,
that's I guess what I was talking a little bit about towards the end. So it is in that 3 to 6 month period, but it's a rule of thumb. Again, everyone's different. Some people really need work for their own well-being, and other people really need that break. But for some people, that return to work plan does need to be carefully considered. So coming back to work 1 or 2 days a week, building up from there slowly, doing half days, being flexible, working from home some days and working in the office others. You know, if that tiger in the grass, that trigger when you cut in that period of recovery is seeing your office, and you have a big response to that, which people have experienced, then how do you just gradually expose yourself to that? A little bit like, graded exposure work there in terms of that stress trigger reminder that's going on in your brain. Yeah. Does Cheryl or Fiona have anything to add? Yeah.
Not to that. No, I thought that was a good response. Someone was just asking about that website I was talking about, so I'll just talk to it, because if I type it in the chat, anybody watching later can't get it. But if you Google NAM, N-A-M, Clinician Wellbeing Hub, you'll get it. It's the Action Collaborative on Clinician Wellbeing. But if you put NAM, it's the National Academy of Medicine. It just pops up. It's pretty up at the front of the thing, and it's updated. It's multi-professional, so it's evidence to do with doctors, nurses, dentists, and yeah, it's very good. It does have tool. If you're trying to do measurements of things, they sort of have sometimes try and sell you tools, but most people aren't doing that. The evidence and the strategies are all free and everything.
That's awesome. Thank you so much for that, Fiona. We've had really positive comments. Everyone's just appreciating your time tonight. Someone's just said here, I'm really thankful for your knowledge tonight. Do you have any recommendations for any training in this area?
I don't know about training. I mean, I did some postgraduate primary mental health courses, because I'm from a general practice background, and then got into this through an education route by doing a master's that then turned into a PhD in clinician wellbeing. So you've got the academic route into it, which is not the slowest, starting that when I was not young. But there are some very good conferences where different people go, mainly psychiatrists, but not always, random people like me, educators and just clinicians who are interested in the topic. So the Australasian Doctors Health one, ADHC, is on every second year. It's in Adelaide in December. I'm speaking there soon. But it's really informative, and it's in different places around Australia or occasionally over here. And then there's a big one that rotates between Canada and the US. Obviously, it's more expensive getting to these places, Canada, the US, and the UK. And that's called ICPH, the International Physicians Health Conference. And they're really good, uplifting, and you can learn absolutely loads. There's workshops as well as, and they're good fun because they're clinician wellbeing conferences. So they're, people there are into looking after themselves. Yeah, so I think that ADHC, the Australian one's a really nice one to start with. That was the first thing I did when I got into this topic.
That's awesome. Thank you so much, Fiona. What do you recommend for bringing up burnout to direct managers? We've got someone here saying that they know of a colleague who's reaching a tipping point, but doesn't want the managers to know in case it affects her job. Any suggestions?
I guess that is a tricky one. You would want to know, I mean, are you working alongside this colleague, and what is the nature of the job? Because I think you're also bound by, are there any negative other risks to consider if they're having, say, patient contact? Are they expected to do things that if they're burnt out and they're not functioning, by not addressing it, they're putting other people at risk? And you want your role to be clear as well. Are you there as a colleague? But it depends on the hierarchy of the workplace as well. So I guess for us, you're a supportive colleague. You tell them, look, we're all burnt out, validate them, normalize it, and give them the support. And you can help facilitate speaking with this colleague's direct line of reporting. So it could be say for us, it'll be our clinical coordinator who oversees the team, who can then, probe further and get them the support they need, whether it's reduced hours or different working responsibilities, getting occupational health involved. So it is tricky, but it will also be tricky if you keep that all to yourself as well, if you know that they are impaired. So that's my take on that.
Just to add to that as well, I think if you think about that period, if they're just in that reaching their tipping point, they might not be aware that they aren't as performing as sufficiently or as safely as they once were. So it could be that conversation of, like Fiona was saying, I'm worried about you, I'm concerned. What can we do? And often sharing the problem, exploring solutions with them, giving them some sense of control and choice, because often we feel like we're so overwhelmed, we're so out of control, we just have to keep going. And actually the reality is quite different. So just that, adding to what Cheryl said.
And and I think someone's in fact, Katie, that feeds into another question that someone's asking about. Can burnout go out unrecognized by someone who's got it and manifest in other ways? So yeah, absolutely. Often we don't recognize it because when you're in the middle of burnout, you're sort of struggling along day by day. You're plodding ahead and you're not looking sideways, and so you miss risks and opportunities. You're just struggling to get by, which is why we make errors and stuff in that sort of mind state. So often we don't recognize it, and there's all sorts of ways that those three strands can manifest. So people become more withdrawn or more sarcastic or more rigid in their thinking, or start questioning meaning in life and all sorts of things. So I think it's a good idea to go and talk it through with somebody, if you're wondering about it for yourself, to go and actually explore it with somebody and try and say, I'm worried actually I might be burnt out. Or you can look up the stuff on that website I've given that I gave you. It's got lots of really good information about burnout. There are lots of places with good information these days. Like I like the Black Dog website's always a very good website for up-to-date evidence-based stuff that explains things really clearly. And so I think it's a good mental health website for looking things up. But I also know that sometimes people phone up to get advice about a colleague. So you can ring MAS or something to get some, or whatever your professional body is, or to talk to a counsellor. Sometimes people will talk about, I'm really worried, is this something I should be worried about, rather than carrying it around themselves. And they make a phone call so that they can discuss that without giving any names about the person, and talk it through with somebody to get some professional perspective on it. So just a few thoughts.
Yeah, thank you. Thank you so much for everyone for answering that question. That was really helpful. Just in terms of accessing NPS or other bodies, you've also got EAP, which can be really useful for some supervision if you're having issues with that as well. And I think that EAP has been mentioned by you guys as well. So there's lots of just really lovely feedback. Everyone's just saying how much they appreciate all the information that you've been providing tonight. It's been really helpful and supportive. And people don't want to see their colleagues go through this, which you don't. And it does impact on the wider, not just on your colleagues, but your patients, as we all know. So it's really valuable, this panel tonight. So really thank you for that. We've got time for a few more questions if anyone has any more questions. Also, if anyone on the panel had anything that you actually wanted to squidge in before, we did have you on very rigid time frames.
Could I just add to that? I'm just, it just made me think that we don't want to get to that tipping point. Ideally, if you can intervene earlier in that chronic stress phase, by taking breaks, by doing those skills that Cheryl was talking about, that's really, really important, because the recovery journey is hard, and it does take time, and it can be really serious, and it really can impact on our confidence, our work life, our financial work, all of that. So I just want to, I know people know it's serious, I'm just kind of drilling it in. Yeah.
I suppose what I'd like to mention is some drivers for change. So depends on whether you're self-employed or whatever, but sometimes people are in an organization that doesn't seem to prioritize practitioner well-being. So there are various arguments you can make for change, linking it to safety and quality of care, but it's now actually in the law, the Health and Safety Act, the Health and Safety Work Act 2016 says that we're all entitled to a psychologically safe workplace. And you know, it's very clear in there that includes work overload. So people have used that to argue for change. The easiest place to find that, to read it up, is to look at on sort of, you know, like on the WorkSafe, or the WorkSafe website has summaries of that sort of stuff. Health and Safety at Work Act, HSW. And I do know people who have successfully used that to say, actually, this isn't acceptable, and we need to make some changes. So sometimes it's good to do that as a group if there's a few of you. But so those are my, you know, I've had to use arguments for getting wellbeing stuff into various things that I teach. So, you know, is it cost effective? Is it causing accidents? Is it, you know, giving quality service? These sorts of things. Thinking about people's drivers for change. That's my 2 cents worth.
That segued beautifully into a question that just got asked, Fiona, so thank you for that. That someone was saying, do you have any tips for when your workplace manager is not receptive to you telling them? So you preempted that beautifully. I'm not sure about this, but apparently someone's just mentioned that MPS have capped funded therapy sessions to 6 in total rather than 6 per year. And does anyone know how to get more funded therapy sessions via MPS?
I'm not sure about that. I did check on their website. It said 6 sessions, but whether there's any flexibility around that, I'm not sure. But yeah, it'll be interesting to find out if there's any room for extra sessions if you need them.
Yeah, I don't know about that. That's a real shame if that has happened. I wasn't aware of that, so I'm going to ring them and find out. Maybe that's a lobby for change at the level type intervention, isn't it? Because I mean, there are more sort of resources around, but I think people really trusted that resource. I think a lot of practitioners do trust it. I think it's worth exploring EAP options because they are confidential. So often people don't trust them, whereas in fact they are confidential because they have to be and they're separate. You know, that there aren't records there that the people who run your workplace get to see. So it's worth sort of asking about confidentiality agreements as a group in the EAP that's being recommended to you. Yeah.
Is there any frequency of supervision recommendations that you would like for seeing EAP or accessing MPS or just getting general supervision, because it is really valuable? I mean, potentially not seeing lots of traumatic things through work, but you do get a bit of vicarious trauma through your patients and things like that, and that ongoing build-up of stress does happen. So supervision is extremely handy in this situation. Do you have what would you recommend if people accessing to help keep that beautiful curve that you were showing us before, Katie?
I just think that really depends on the level of experience. Obviously, we need more supervision as we're starting out, and as we get more confident and more comfortable with more complex presentations and cases, that need does decrease. As a team, though, I think there's an interesting thought around, could there be team supervision on an organisational level? And obviously I don't work in a government department or anything like that, but there could be, you know, bi-yearly or every 2 months or something, some kind of check-in around this in terms of team well-being, team workload, chronic stress levels, things like that. I'm not sure, but that's just a thought. Yeah. I think it would be beneficial in any way.
Yeah. Team
very beneficial to get, you know, a lot of practitioners will have supervision about once a month in a you know, ongoing ways, but so not when something's wrong, but it's just a routine, so they'll go along once a month. Some people join a Ballant group or a Valent group. They're more popular now, where it's a group of practitioners. Sometimes they're just from one discipline and sometimes they're multidisciplinary groups. So if you look up Valent groups, there's a New Zealand Valent group website, and often there they'll dissect sort of difficult problems that have happened as a group. It's a very specific process that you follow. There's one person presents a case and there's a sort of process for following. A lot of people find them incredibly helpful. and stay in their Valent group. It's a closed group of people that you go through with the same cohort. So there's definitely some things that are worth exploring. Supervision is a great way to sort of have a regular way of offloading and a place to take something that was difficult. So I would highly recommend it. I think it's a real shame that we don't need to do it. I just wanted to comment, someone's asking about, talking about an experience of sort of trying to talk to manager and being belittled about it. And, I think that's such a shame. I'm sorry that happened, and it's not acceptable. And I think sometimes people do that in a position because they don't know what to say, and they just want you to get on with your job, and they don't know the risks and, to health and safety and to quality of care and all that sort of thing. So I think that a good way to lobby for change with that is as a group, because if you're trying to address somebody above you in the hierarchy, it's good to get a few of you and just go along and say, right, we are all decided we want some well-being initiatives. We've set up a wellness committee, or, as a group, we want to prioritize this because we know it makes us deliver a higher quality, whatever their drivers are, higher quality care or, more professional service, whatever. And so I would do it as a group and just say, we want some change around here. Individual conversations, people can not handle them well sometimes, which is distressing for the person who's actually being brave enough to seek help and admit that things are difficult. So I think many of us have been on the receiving end of those types of conversations in our lives.
Yeah, thank you, Fiona. There's a question here about a correlation between chronic fatigue syndrome and burnout, and is there any correlation? Anyone would like to speak to that? To see that at all?
I mean, Cheryl probably know more about it, but there's overlap with all these. There's overlap, with things like depression, for instance. Depression can lead to burnout, and burnout can lead to depression, and there's overlap. If you look at a study where they take people with both, there's a big overlap of people. So, I mean, if you think about it with diagnosis, it's a list of symptoms that we're all saying, if you've got these, then we're giving you this label, but it's not that clear cut. As a suffering human being, we have things that could be fitted into one box or another. So that's my take on that.
Yeah, and that also ties into Shri here, who said that she thinks they think compassion fatigue needs to be considered as a contributor to burnout. Yeah, and I guess that's it's part of that.
Yeah, but it's not necessarily a linear thing always. It's more messy than that.
Yeah,
but it's stress. If we're under stress, we're going to react in any way, in all sorts of individual ways as well. But burnout is one of those outcomes of stress, as is depression, as is chronic fatigue, as is
Lovely. Well,
they also that like what Fiona mentioned, there's that diagnostic overlap, and then if you have chronic fatigue, you can be predisposed to burnout, and also you tend to have more somatic symptoms, while people who are burnt out might have more depressive symptoms. So it is an interesting correlation, and studies have looked into that as well. And
but chronic disease isn't work related necessarily as well. Burnout's a work related phenomenon. Technically, or people do refer to carer burnout actually, but technically the official diagnosis is a work related condition.
Yeah, well, I guess then you get that overlap with vicarious trauma or compassion fatigue, as someone mentioned as well. So it is all plugged in. Wonderful. Well, that seems to be all of our questions for tonight. So I'm just going to thank you again to everyone for presenting tonight and for taking the time this evening to give us all the information that you have. It's been extremely invaluable for me, and I'm sure for all of our participants watching as well. So I hope everyone has a good night. Thank you again for joining us.
Kia kite. Ko Mary.